Hello, I'd like to give an update on CPIC's newest guideline, which is a big expansion of the G6PD guideline and covers many more drugs than the last version of this guideline had. I'll also talk a little bit about how we've been implementing this guideline at my institution, St. Jude. G6PD deficiency is one of the oldest known pharmacogenetic polymorphisms, being discovered by Pythagoras in ancient Greece, and it's known to predispose individuals to acute hemolytic anemia caused by oxidative stress in red cells, and drugs can be the source of that oxidative stress. So G6PD is the major source of NADPH in erythrocytes, and in the absence of G6PD, there is not enough NADPH in erythrocytes, and therefore there's not enough NADPH to reduce oxidative stressors like hydrogen peroxide. This is depicting the hydrogen peroxide that's released when one uses the drug resveratrol or its pegylated form pegloticase in hyperuricemia. It directly hydrolyzes uric acid to allantoin, but the byproduct is hydrogen peroxide, so that creates a lot of oxidative stress. And in the presence of that stress, erythrocytes can lyse. G6PD deficiency is an X-linked recessive disorder. It's the only actionable X-linked pharmacogenetic polymorphism covered by CPIC so far. It affects males more than females. And the anemia can be triggered not only by medications, but also by infections, stress, or foods such as fava beans. And that triggering by infections has confounded some of the putative drug associations with G6PD deficiency and acute hemolytic anemia. It affects over 400 million people globally. It is more common in places that are close to the equator, such as Africa, Asia, the Mediterranean, the Middle East, and that's thought to be because G6PD carriers are partially protected against malaria, and it does result in tens of thousands of deaths worldwide. The highlights of this update of the guideline included that we really wanted to tackle which drugs to include. So it covers a much larger number of drugs than any other CPIC guidelines, 47 medications. And we took the time to go through our evidence review and classify drugs as low to no risk, medium risk, or high risk, or in a few cases to have no recommendations based on our evidence review. It's unusual because currently there's probably more common testing performed by phenotype G6PD activity than by genotype in the clinic, but there's growing evidence that supports the utility of genotype, and it is the only actionable gene on the X chromosome. That means it's easy to haplotype, so if you genotype males, then you're going to find all of the variants in that individual. However, it's has the unique characteristic that there will be incidental findings because it's very easy to detect sex chromosome abnormalities when one does G6PD genotyping in a male. You should only have one variant reported back, and males who have two alleles reported back are likely Klinefelter syndrome patients. And so you have to make accommodations for how you're going to handle such incidental discoveries of sex chromosome abnormalities by virtue of G6PD genotyping. Also, I'll talk about in a moment that X-linked mosaicism has an impact for interpreting genotype and phenotype in females. This table lists the drugs that underwent evidence review by our CPIC guideline authors for whether they were associated with acute hemolytic anemia in the setting of G6PD deficiency. And you can see that this list includes several sulfonylureas, as well as several sulfa antimicrobial agents. And these are important because these all turned out to be low to no risk drugs after the evidence review. G6PD differs from many other CPIC guidelines in that the vast majority of publications are simple case reports with no controls for what could be other causes of any hemolysis that was observed. So we actually took the time in our evidence review to highlight in red citations that did not support the association of that drug with anemia in the presence of G6PD deficiency. And we put a lot of emphasis on reviewing negative as well as positive evidence. As for all CPIC guidelines, we did assign a level of evidence, in this case for the association of the drug with G6PD deficiency associated hemolysis. And high evidence was when there were good quality studies or case reports with strong mechanisms of action, especially if the drug was rarely used and no convincing contradictory data. Moderate evidence, medium quality studies or case reports with a plausible mechanism, and again, little to no convincing contradictory data. And we took as weak evidence only case reports or in vitro evidence, especially if the drug was commonly used. And then in some cases, there were studies that refuted the involvement of G6PD in hemolytic anemia. We also took the time to develop criteria for studies that showed the lack of association of a drug with G6PD deficiency associated hemolysis, because it turned out that we did classify many drugs in that low to no risk. So of the 48 drugs that we reviewed, we put them into 3 main categories. And by being a high-risk drug, that translates into prescribing actionability. That means to avoid that drug in G6PD deficiency if at all possible. For medium risk drugs, to perhaps use the drug, but with caution and frequent monitoring for acute hemolytic anemia. And in the low to no risk group, we put drugs that we thought there could be used without regard to knowledge of G6PD status. We did have some drugs for which we put no recommendation, and those were drugs where we could find absolutely no relevant published articles, even case reports linking them to G6PD deficiency. So we did specify what the criteria were for assignment of drugs into the high risk, medium risk, and low risk groups. And again, that had to do with the strength of the evidence. We also take into account the strength and pervasiveness of regulatory agency warnings against use of that drug, realizing that for some of those drugs, their usage might have been curtailed by a long history of regulatory agency warnings. We summarized regulatory agencies from 4 such agencies: US, European, Japanese, and Canadian, and classified their warnings as either caution or avoid categories. And you can see by the color coding in this table that there were many drugs for which regulatory agencies did not have concordant levels of warning. Resveratrol is one of the few where all 4 agencies recommend avoiding. It did turn out to be that all FDA avoids for putative G6PD drugs turned out to be in our CPIC high risk category, but there were some avoids by other regulatory agencies that did turn out to be low to no risk by CPIC. And there are many drugs listed as cautions by agencies that either turned out to be low to no risk or no recommendation from CPIC. So that was one reason we wanted to go through this in a little bit of detail, because many institutions use software that may have classifications of drugs based on their putative G6PD status. And at least at our institution, that's meant that we've had to revise and manually make revisions to our software to place drugs into these high risk, medium risk, and low to no risk drugs. The drugs on the high risk list are relatively few: dapsone, methylene blue, pegylated resveratrol or pegloticase, high dose primaquine at a standard dose or higher, the related new anti-malarial tefenaquine, and toluidine blue, which of course is very rarely used. We did put primaquine in a separate category because it's been so widely studied by the World Health Organization, the CDC, and other groups to try to determine what regimens might be safe to use even in the absence of knowledge of G6PD status in third world countries, for example, so that primaquine can actually go into 3 different groups of risk depending on the dosage used, with the highest dose in the high risk group, a medium dose in the medium risk group, and a single low dose regimen that has been widely used worldwide. We put in the low to no use category. Again, CDC and World Health Organization recommend such regimens without regard to G6PD status. The only drug that ended up in the medium risk group other than medium dose primaquine was nitrofurantoin. And you can see there's many drugs that got placed in the low to no risk group, including drugs like chloramphenicol, chloroquine, several fluoroquinolones, hydroxychloroquine, and importantly, sulfa drugs. So that's quite a downgrading of risk for a drug combination like trimethoprim sulfamethoxazole that's quite broadly used antibiotic, especially in our population at St. Jude. This is really making a tremendous difference because now that we are no longer withholding sulfa drugs from our G6PD deficient patients, we no longer have to use alternative agents like inhaled pentamidine for pneumocystis prophylaxis in such patients, and it's really saving our healthcare system a tremendous burden. And then there are these medications that went into the no recommendation category, which includes more of the oral hypoglycemics, some fluoroquinolones, and others, where there just wasn't enough information. We did review an academic review that was done about 10 years ago. That was a pretty careful review of publications, and they also downgraded many putative G6PD drugs into the low to no risk category that they deemed could be used without regard to G6PD status. And there was very good agreement between those drugs that they classified as high risk and the ones that CPIC ended up classifying as high risk, with the addition of tefenoquine, which is a newer anti-malarial. So, for example, this is the kind of breakdown of the evidence for a drug like resburicase or its pegylated cousin pegloticase, which is had strong evidence for being a high-risk medication, not on the basis of very high-level evidence, because there actually aren't controlled trials, but there's many case reports. And of course, there's a very strong mechanism of action because hydrogen peroxide is generated as a result of the mechanism of action of resburicase hydrolyzing uric acid to allantoin and hydrogen peroxide. So this stays on St. Jude's avoid group, and this is an example of the kind of interruptive clinical decision support alert that our clinicians will see if they prescribe resburicase to a G6PD deficient patient. And we have similar alerts for the other high-risk drugs, dapsone, methylene blue, primaquine, tefenoquine, and toluidine blue. This is also, and this of course is included in the suggested clinical decision support language with each CPIC guideline, but we do have suggested wording for those who want to give a pre-test alert for the prescription of a drug like resburicase, that's a high-risk drug, in the absence of any knowledge of G6PD genotype or G6PD status. At our institution, we do flash a pre-prescribing alert at clinicians warning them that they may want to find out G6PD status before going forward with that drug. So a drug in the medium risk category is one like nitrofurantoin, where there's moderate level evidence without strong biological mechanism for risk in patients with G6PD deficiency. So at our institution, this gets a caution. The wording is a little bit different. Nitrofurantoin may cause hemolytic anemia and should be used with caution. And we would use the same alert for lower dose primaquine. And again, the CDS alert language that one can find on the CPIC site, there's a screenshot of it here, and you can see that every drug will have different wording depending on its category for both the potential pre-test alert and post-test alerts for that drug. And then again, to emphasize that we took a very commonly used drug like sulfamethoxazole and have put it in the low to no risk group. It does have some regulatory warnings, although they're inconsistent among regulatory agencies, and the evidence is extremely weak associating with sulfamethoxazole with anemia. And in fact, there are quite a few several controlled studies showing the safety of sulfamethoxazole in G6PD deficient patients. So again, listed here in red are those conflicting reports in addition to the positive results of no association with anemia in G6PD deficient patients in several different studies. I just want to spend a minute talking about G6PD testing. To categorize alleles, we've continued to use the categorization that the World Health Organization put through several years ago, where alleles are classed into 5 different groups. Basically, that's 4 different groups. Class 1 are only those very severe low activity alleles that are associated with chronic non-spherocytic hemolytic anemia in the absence of a drug challenge. That's extremely rare. Way less than 1%, whereas the majority of patients that have G6PD deficiency have either class 2 or class 3 alleles. The WHO recognizes that these distinctions between activity associated with class 2 and class 3 alleles are actually very difficult to maintain, and because both confer deficiency in a male, there's really no distinction between class 2 and 3 alleles. Class 4 alleles are normal, and class 5 alleles has only been reported once, and so is really not used anymore to denote very high activity alleles. Just to mention that we're aware that WHO is revisiting their classification of these alleles. They're planning to go to a new system, which would take care of this issue of pooling together class 2 and 3 alleles into a separate group. But because there hasn't actually been a reclassification of all alleles at this point, we stuck with the old system for now in the CPIC guideline. So assignment of G6PD phenotype can be based on genotype, as is true for any CPIC genes, with the majority of people being normal. And that's a person with an X chromosome who carries at least one non-deficient allele, or a person carrying 2 non-deficient, a boy, a male with 1 X chromosome carrying a non-deficient allele, or a female with 2 alleles, both being class 4. Of course, they can be heterozygote for class 4. And deficient people, the females have to both alleles have to be class 2 or class 3. And of course, males just need 1 class 2 or class 3 allele. The deficient with CNSHA we discussed is extremely rare, but those alleles are defined in the tables. And then I'm going to talk a little bit more about this variable phenotype, because that's unique to G6PD, and it applies to females who have 1 non-deficient allele and 1 deficient allele. And it's not possible to assign G6PD phenotype based on genotype alone in such individuals. I'll talk about that more here on this slide. So because it's on the X chromosome, males have 1 copy. Here, let's say that the red denotes a deficient allele. And so that single allele genotype determines the phenotype for the individual. But females have 2 copies of the X chromosome. However, X undergoes mosaic X chromosome inactivation during development of the precursors of cells like red cells. And the ratio of cells that have the deficient allele inactivated versus the normal allele inactivated can change over time, and it can change among different tissue types. So it ends up that heterozygote females can have G6PD activity phenotype that ranges all the way from deficient to normal. And it's just simply not possible with current technology to determine a female's G6PD status based on genotype alone if they are in this heterozygote category. And that makes up about 4% of females in the US. These are our data genotyping a couple of thousand patients that represent a diverse population in the US. And you can see that 3% of our males are deficient, the rest are normal. Only 1% of our females are deficient, but 4% of them are heterozygote and then therefore go into this variable phenotype category based on genotype alone. And that translates into our table 3, which is our prescribing recommendations for the use of high-risk drugs based on G6PD phenotype. And that's again broken down by normal, deficient, deficient with CNSHA, variable, or an indeterminate genotype. And while deficient patients, of course, it's just avoid use of the high-risk drugs. For variable patients, the recommendation is that to ascertain G6PD status, enzyme activity must be measured, and then the drug use should be guided based on the assigned phenotype based on the activity, which is not a completely satisfactory answer for these heterozygote females, because the G6PD activity test itself has quite a few limitations. So the advantages for G6PD enzyme activity tests at many places and out in the field, even there are tests that can be done extremely quickly with the result available within minutes or hours. But the limitations are, by nature of measuring G6PD activity in blood, that it's affected by hematologic parameters quite strongly. So an elevated white cell count, retic count, of course, the presence of a recent transfusion, or critically low hemoglobin can all have strong artifactual effects on G6PD enzyme activity, making it be unstable and sometimes misleading and not reflective of the patient's actual genotype. Overall, the most common class 2 to 3 variant is this A- variant, and you can see this is a snapshot from 1,000 Genomes Project of some of the alleles that may be more common, and really it's only that A- allele that's present at any appreciable frequency, which is it tends to be an African allele, more common in individuals with African ancestry. Of course, there are some isolated, especially Asian and Middle Eastern populations, where the frequency of variants may be higher and may not be well reflected by 1,000 genomes. But overall, in many populations, it's quite easy to capture the most common class 2-3 alleles with a genotyping test. In fact, we studied about 6,000 United States citizens, and we did both sequencing and genotyping using the pharmacoscan array. And of all the 2 to 3 class variants that we saw, which are highlighted here in red, there were all but one of them was included on the pharmacoscan array. And of all of the class 2 to 3 variants observed in these 6,000 patients, 83% of them were either the A- or the related Asahi alleles. So most of the other rare alleles that were seen were basically singletons that were extremely rarely observed. So although, like for any genotyping test, one must be careful to think about the population that you're interested in and whether the frequency of the variants may be high enough in that population that the test should include those variants. At least in the American white, black, Hispanic population, most of the variants can be captured with just genotyping a few of them. We apply an algorithm to patients at St. Jude, and we do tests for G6PD activity on a clinical basis for many patients. So we had about 450 patients with genotype and activity results, and there was good agreement between genotype and activity, with the exception of 5 patients. So 2 patients who had a normal genotype seemed to have deficient activity at diagnosis, and 3 patients who had a deficient genotype seemed to have normal G6PD activity at diagnosis. So we drilled down a little deeper into these discordancies, and basically in the 3 patients with normal activity who were then reassigned based on their genotype and repeat G6PD activity, they all had abnormal hematologic parameters, or in one case, unfortunately, because we thought the patient had normal G6PD activity, we did give them resburicase, and they experienced severe methemoglobinemia and hemolysis on the basis of that. The 2 patients with provisional deficient activity were actually eventually reassigned normal phenotype based on the fact that they had no detectable variants by genotype and based on repeat activities that became normal. And again, because G6PD activity measures can be so strongly impacted by hematologic parameters, you have to be careful that G6PD phenotype assigned by activity may not be true for all patients. So overall, that's about 1% of patients where there was discordance between phenotype and genotype. But interestingly, if you look at the 20 patients who had deficient activity initially, 10% of them, or 2 of them, were actually had normal activity with subsequent studies. So as a result of this, we've really taken to be more careful when assigning G6PD deficiency based on activity to see if that holds up over time. So in the case where we have a normal genotype with deficient activity, we've essentially decided to keep reassessing those patients over the next several months to see if their activity ever becomes normal. And in all cases we've done so far, it has. Of course, if somebody has a deficient genotype, they really can't have normal activity. So we assume that the deficient activity applies when the genotype shows that they are deficient. One other thing I wanted to mention is all of our interpretations of the evidence are confounded by the fact that there can be non-drug triggers of hemolysis, as I mentioned, especially infections, because so many of the putative G6PD high-risk drugs are antibiotics. It's really possible that the infections were the cause of the hemolytic anemia and not the drugs, as well as just the presence of hyperuricemia or sepsis alone can trigger acute hemolytic anemia in G6PD deficient patients. Also, because, and I mentioned this, there really are disease-related incidental findings for this CPIC guideline and this pharmacogene because of G6PD's location on the X chromosome. There's just no way to look at G6PD genotype in a putative male that actually has Klinefelter's syndrome, where they may have an extra X chromosome that was previously undiagnosed. I think we've seen this in 3 or 4 patients at St. Jude since we started doing this preemptive genotyping. And in every case, the Klinefelters had gone undiagnosed. A genetic counselor was involved in helping to confirm this diagnosis with the family, and it actually helped in management of the patient to make that diagnosis that was first hinted at by the G6PD status. So I'd like to close by acknowledging my colleagues, especially at St. Jude, who've been involved a lot in the G6PD guideline, particularly the PI of our local protocol, Serene Haidar, and a number of residents who've worked on G6PD over the years. And of course, to acknowledge all of my colleagues in CPIC and our team of internationally based authors for this CPIC guideline, who really worked hard on reviewing many, many hundreds of published reports to come up with the recommendations in this guideline. And we also got helpful reviews from some colleagues involved in the World Health Organization to comment on our final recommendations and classifications. So I thank you for your attention, and I'll be happy to take any questions on this. Thank you.